Right, so next up we have Paul Thomas, who's Professor of Analytical Science Chemistry at Loughborough University. Paul has a general interest in determination of VOCs and particular interest in volatile breath biochemistry, as well as clinical studies with respiratory and oncology teams. Paul's been looking at breath and volatile organic compound applications in emergency room medicine. The resultant multidisciplinary studies have integrated IMS techniques into remote piloted airborne systems, skin analysis for contamination screening, and a rapid breath test for mass casualty applications. Paul will talk about his work in COVID-19. Thank you. Over to you, Paul.
Hello, everyone, and thank you so much for asking me to share our work and hypothesis that it's possible to detect COVID-19 in the breath of people with respiratory symptoms infected with the SARS-CoV-2 virus. I'm speaking on behalf of a wonderful group of people who came together in a loose coalition in March of this year, based in Edinburgh University, Clinic in Dortmund, GAS in Dortmund, IMSPEX in Wales, and my colleagues at Loughborough University. Our story starts a little while ago in that we were working on triage in a mass casualty scenario involving chemical, biological, radiological, and nuclear agents. And we were looking for markers of radiation exposure. This work was being driven and led by this team of fantastic colleagues. As part of the Toxic Triage project, we ran a series of technical field trials in Europe. We ran one in Greece, and we ran one in Finland. And it was during those trials we were able to demonstrate convincingly that gas chromatography, ion mobility spectrometry could be used by nurses and doctors in an emergency room for fast triage of their patients. In Finland, we were running at 36 patients in an hour, looking at trace levels of target volatiles in our participants' breath. And previously, I've shared with you our work in the Athens exercise, where we demonstrated the same techniques, except this time we were working in the field with people heavily encumbered with PPE. At the beginning of this year, we found ourselves in Edinburgh, working with our partners there, following up on our previous work with radiation. We discovered that sulfur volatile organic compounds in breath appear to elevate following exposure to a radiation burn, and that the signal of a radiation burn develops over some hours. These are data taken from 6 hours. They show that combined with a tumour biomarker, there seems to be a signal indicating radiation exposure that differentiates people from before radiation and after radiation at 6 hours. Not everybody we tested showed this response, but those who did show the response showed a significant response. We were investigating this phenomenon, and we were well on our way to collecting another lovely set of data to enable us to check and verify whether our initial observations could be reproduced, and if so, whether we could improve upon them. Well, in March, our study was shut down and our colleagues were redeployed to other duties around the hospital as the clinical team sought to manage the COVID-19 patient surge. We pivoted into the emergency room at the Royal Infirmary, Edinburgh. Simultaneously, and some distance away, another clinical team in Dortmund were doing exactly the same thing. And our colleagues at GAS had deployed an identical instrument, running a slightly different methodology into the hospital at Dortmund. Both of these teams were unknown to each other at this time. They had the same goal. Was it possible to take breath samples and analyse those samples in the emergency department from people who were ill with respiratory disorders and potentially had COVID-19? Could we detect COVID-19 in such people, and could we rule out COVID-19? The two studies found each other thanks to GAS, who said, why don't you two cooperate? And so halfway through the study, we started exchanging data and supporting one another. Our plan was to get 200 patients with respiratory symptoms. That work is still underway. We wanted to get some healthy volunteers from the same environment. That work is still underway. The recruitment really now is of a minimum of 200 patients, of a wide cohort, different diseases, and that's ongoing. So it's a developing story. So there is on-site, non-invasive breath sampling and collection and analysis using gas chromatography, ion mobility spectrometry. We're using a Haldane tube sampler. It's made from polypropylene. It's a small 10 ml Eppendorf tube fitted with non-return valves. Our patient blows gently as much as they can through the tube. We take 5 mils of the end tidal portion of breath, inject it onto the instrument. Half a mil of that is injected onto the column, analysed capillary gas chromatography with ion mobility spectrometry detection. We've found that it's easy for clinical staff and patients to use. The data I'm going to show you is obtained from 98 participants. 31 of them had confirmed SARS-CoV-2 infections and had COVID-19. Other diagnoses included asthma, COPD, bacterial pneumonia, and cardiac conditions. On average, we isolated 80 features from the GC-IMS data, and these features were processed to see whether or not we could detect COVID-19. We brought the two methods data together, and the teams in Dortmund and the team in Loughborough had evaluated the data independently of each other and had come up with candidate markers. This image shows how, when we brought our two sets of data together, we found that there was similarity between what they had discovered in Dortmund and what we had discovered in Loughborough and Edinburgh. Processing of the data then started at Loughborough, where we integrate the background subtracted ion mobility spectra collected from the GC column. This is the top right-hand trace. And once we have background subtracted that data, we then start to integrate the features and reduce them to a single data point. Then we extract those 80 features. They are registered against retention time and IMS drift time. These are then put into our workflow. Both teams use slightly different workflows, but they followed the same general principle of extracting features and then using PCA in order to detect whether or not we had differentiation. In Loughborough, we work with SIMPCA-P and we use orthogonal partial least squares to reduce the data, identify our candidates, and then take them through to non-supervised principal component analysis. When we did all of this, two teams found that we were detecting aldehydes, ketones, and methanol. We think that this is consistent with the multi-system presentation of COVID-19. We saw ketosis with acetone and acetone-butanone clusters. We saw inflammation with ethanal and octanal. And we saw gastrointestinal effects with significant changes in methanol. The literature shows that these have been previously reported as markers of ketosis for the ketones, inflammation for the aldehydes, and the methanol has been indicated in studies looking at inflammatory bowel disease. Using these data for principal component analysis in the Edinburgh set enables us to produce these clusters here, where we're able to identify clear negatives and clear positives with borderline classification in between. Similarly, with Dortmund data, slightly different story, the same general outcome, but using these data enabled us to classify into positives, negatives, and borderline cases. Many of the borderline cases were quite complicated in that there was delay in sampling, there were perhaps multiple morbidities present. We propose a GC-IMS breath score for COVID-19, which is the summed intensity of these aldehydes, the ketones, and another feature that we have yet to identify, which we label feature 144, and divide this by the methanol concentration, gives us this GC-IMS breath score, enables us to rank participants from those who are shown to be COVID-19 from those who are shown to be COVID-19 positive. Feature 144 was also found to be predictive of more serious outcomes, and it was most abundant in those participants who spent the longest time in hospital, needed intensive care, and in some cases did not survive the disease and went on to die. This work has now been accepted for publication by Lancet eClinical Medicine. I would invite you to study that paper and please feed back to us. And the gas chromatography RNP spectrometry is a selective detecting system. I think there may well be other compounds that are useful in breath, particularly the hydrocarbons. And I hope very much that if you are working in this area, that our work is useful and is helpful to you. For now, I simply note that we really would like to be continuing the tests. So far, our efforts to secure funding to scale up our work has not met with success. However, this is what we're seeking to do. We're sending instruments to Sri Lanka to look at the prevalence of these markers in patients in a completely different clinical setting. And we're collaborating with partners from the EMBA consortium who are also running a study to see if we can get some cross-data marker validation. And it's a hypothesis that I'm offering. We do not want to be like the beavers eating the lumberjack's leg. It's still preliminary, but we think we may have something useful to share. Thank you very much.
Thank you for that, Paul. So if you could start your camera and microphone, we've got time for some questions. There we go. Fantastic. Thanks so much for that, Paul. So we've got a few questions coming through. I was hoping to open the floor first. So in some of the VOCs that you mentioned are, acetone, octanol, isoprene. So obviously we see these across, lots of different studies. So I suppose the question is, do you think these actually would be specific enough when you compare it to other types of infection? And when you broaden that a little bit further and kind of think about the specificity related to other types of diseases, full stop, and other comorbidities, you mentioned likes of IBD, for instance. Do you think the specificity is going to be problematic here once it gets rolled out into a larger study?
I think it'll be challenging for sure. It's the effect size that's driving this, I think, in that everybody that we sampled was already in a hospital emergency room. They were all ill, and we were trying to triage them between, they're all COVID queried. We wanted to see whether we could screen COVID-19 from non-COVID with people coughing, spluttering, having difficulty breathing in the emergency room. And it's not just one compound that's going to help you here, it's the whole panel, and all the panel has to be moving in the right direction for you to get that differentiation that indicates it was COVID-19 in these data. We need more. We need more data, and unfortunately now we're in a position to be collecting more data. And I saw a tranche of data come in late last night, and I say, do I try and get this into this conversation today? And I thought, that's not doing justice to the team who collected it. I need to give that some due diligence and thought.
Thank you. Question here, how do you avoid potential transmission of the virus from patient by the breath sampling?
Okay, so the biosecurity of the process occupied us for quite a while. The sample is disposable. It's a non-aerosol generating procedure. We're not asking them to blow out hard. They're breathing normally as they would in a normal circumstance. It's done in an environment where everybody is wearing PPE anyway. It's a red zone within a hospital. Our main problem is the disinfectant protocols that go on around the equipment in between each patient's use. The patient doesn't touch the instrument. They touch that little piece of plastic. A syringe is injected into an instrument, which is a heated inlet. We have biofilters on all exhausts of the instrument. And that's about the best that we can do.
Okay. There's another question. What could be the reasons for partial detection of radiation markers in subjects? And a follow on that was, would 10 mil of N-titled samples suffice for VOC breath testing without any prior pre-concentration? And then last was who are the controlled subjects for the COVID study?
Wow, there's a lot there. Okay, so I'll try to take those in reverse order. The controlled subjects are the people who didn't have COVID-19. So we had gold standard clinical adjudication in this study. So it had to be a combination of CT scan, clinical judgment, and PCR. And only when those were all in alignment and agreed would we accept a SARS-CoV-2 COVID-19 diagnosis. Where there was disagreement between those three things, we didn't include it in the study. And those who were all absolutely negative were the ones that we were controlling against. The pre-symptomatic or asymptomatic study that we want to run, that's ongoing in Edinburgh and hopefully in Dortmund, and something that we're very keen on doing. And there will be a new type of control in due course. So that was the controls. Oh gosh, help me. Then the next one.
Next one was would 10 mil end-tidal samples suffice for breath testing without prior pre-concentration?
So I'm being shamelessly promoting an upcoming technical note on the Peppermint study series, where we look at exactly this question with GC-IMS. It's not as gloriously rich as you'd get from a GC TOF with 1 liter of breath and a 50,000-fold enrichment. You'll get about 80 compounds. And the question is, those 80 compounds are all got a proton affinity higher than water. You're going to see the compounds associated with oxidative stress and ketosis for sure. The interesting hydrocarbons you're not going to see, of course, with GC-IMS. You need a different ionization source for that for another day. So you don't see a lot, but you see enough. The thing about this approach is we can run it out of the back of an ambulance, and we have done. And so to get femtogram detectability, selective identification of these markers, just about anywhere you like, in any setting, whether it be airport or care home or hospital emergency room, I think is what we're trying to demonstrate here.
Was it nickel ionization source, just out of curiosity?
This is a tritium ionization.
Tritium, okay.
I'm not claiming it's the best breath analysis technique in the world, far from it, but it's for use in spartan and acute settings.
And then the question here was, what could be the reasons for partial detection of radiation markers in your subjects?
Oh yes, that's a whole different story. It's the burn inside you following radiation exposure is developing over time, and you have a cascade of interactions taking place around that injury, and I can conjecture all day long about what may be causing the sulfur compounds, but I'm just going to say that read our paper in the Journal of Breath Research. We did quite a lot of thinking and hypothesizing there. But I think it's liver engagement with a whole load of oxidation and burn products, and it's the protective mechanisms involving a range of sulfur-containing compounds that we see at work. Is our initial working hypothesis.
There's a few questions that relate back to the specificity.
If I may, Billy, I also want to note that we did see a lot of hydrocarbons with the radiation burns, and I'm for sure that was they were very strong markers of burn injury, but we were interested in the sulfur-containing materials.
So there's a few kind of related questions around the specificity question. I suppose one that's kind of popped up here saying, in the future work, will you be expanding to look at other types of respiratory infections? I suppose, again, other types of broader patient cohorts where you may exhibit similar directional changes of some of the VOCs at least.
Yeah, I forgot to say that this study's been run on fresh air and love, in that there's been absolutely no funding for it. So we've really been working on the goodwill and support of nursing and staff and doctors in the clinics. We don't have a lot of time for rigorous screening and inclusion and exclusion criteria. At the moment, our inclusion criteria is a COVID-19 query, and that's when we take a sample. And we know from this study and others that a significant proportion of those will have a range of other respiratory symptoms and diseases, and that's how they are included. So we don't have this targeted approach in that the samples have to be taken in the same environment, by the same team, in the same space as we're getting from the COVID-19 patients. And the nature of the disease, it is acute, it's in a medical emergency, and it has to be very light touch, contact with the patients.
Excellent. So we've got time for one more. Can you comment whether the ketones and aldehydes were identified in GC-IMS by matching the standards? So I think that's come back to the, how do we know what it is?
Yes.
Questions popped up a few times over the last couple of days.
This is I was terrified about sharing the results and being so arrogant as to give names to these compounds, for sure. However, I think it's helpful to give names to what our best guess is. No, we haven't had time to run pure standards through the instruments because we've been busy taking breath samples from people in hospitals with them. One of the real challenges you have with these high throughput GC-IMS approaches is the convolution, the coelution of peaks into the IMS. And that is going to give rise, in many instances, to mixed cluster ions that makes a reliable identification and quantification of materials really tricky. So the sharp eyes amongst you would have looked at the Dortmund box whisper plot for the GC-IMS COVID-19 breath score and say, well, that doesn't look as sexy as the one from Edinburgh does. Were you tweaking the data there, Paul? No, we weren't. But the Dortmund study didn't quite run long enough on the GC to catch a feature 144. So the 144 score couldn't be included in their breath score. However, getting the GCs to align in an IMS technique is really tricky and critical. So the identification is based on the GAS database. They have an extensive database, and it's an opportunity for me to really praise the technical team there, particularly Daniel Sanders, who's been our guardian angel in many senses for this study, and that he has run huge numbers of samples and standards through GC-IMS, has extensive libraries, and it was through his expertise work and repositories that we assigned tentative identities to these compounds.
There was one other question I forgot to ask earlier. How did you arrive at the COVID-19 score equation?
So the COVID-19 score equation is we've got a panel of markers, and the hypothesis is that some markers will go up and some markers will go down. So you can combine those in a number of ways, and we tend to use a ratio. So those compounds that are going down combined with those compounds that are going up give us a definitive score and enable for straightforward clinical determination. It's to make any results that we get tractable to a wide range of clinical practitioners across a wide range of settings, whether it be in a rural clinic in Sri Lanka or a rather more sophisticated international centre such as Edinburgh.
Excellent. Well, thank you so much, Paul. There's a few other questions which I'm sure we'll be able to give type answers to as well. So appreciate the time today, and thanks so much for sharing that really interesting research, and good luck. Thanks.